I have given talk on newborn screening, and the title is usually Newborn Screening, Our Experience of Outreach Program. So really this happened because our Sanjay Gandhi PGI does not have a very high workload obstetrics department. And hence, when we decided to go for newborn screening, which is a sort of dream for pediatricians like me and Dr. Vijaya Lakshmi, we realized that we had to go to some other hospitals in Lucknow and around Lucknow where there are 5,000 deliveries per year and so. And this sort of helped us to build up the newborn screening program the way it should be. What I will highlight that this is where we get samples from other places, and then the expertise in the tertiary medical care center teaches the peripheral hospitals or women and children who are belonging to very low socioeconomic strata and are into villages, so the expertise reaches there. And this is something which has been possible because of this model of newborn screening program. And today I got the opportunity to look at the newborn screening program, what we have done and its outcome from the other way. That as it is an example of an outreach program from a tertiary care hospital in a big city or a capital city for peripheral centers. So I would try, naturally the presentation remains similar, but the perspective really changes, and it did change for me. And it also reflects the journey from my 30 years journey from 1989 to 2019. So as Dr. Vijaya Lakshmi said, it's my personal journey from mother to grandmother, trainee student to head HOD. And during these 30 years, there were a lot of changes in India, which was considered a third world country, now as digitalized in India. The literacy rate has increased to 70%, life expectancy has increased, and our income has improved. The most important thing is infant mortality rate, which has decreased to less than 30. And this literacy rate, increase in literacy rate and decrease in the infant mortality rate are the most important things which I would like to highlight for the necessity and of the newborn screening program as well as the success of newborn screening program. The other important thing which I want to mention and different, I came to my mind and is different from what we started in 1989 as a screening program for prevention of beta thalassemia. So I started my career as a research officer in a program where we wanted to screen all pregnant women in Lucknow for beta thalassemia carrier status during pregnancy, so that we can identify the couples who are at risk of having a child with beta thalassemia major and has had an ambition of sort of control of thalassemia major problem from all over UP. Of course, nothing like that happened during 30 years also, though there is some awareness about thalassemia screening amongst medical doctors as well as laypersons in India. So when I started in 1989, I was going to Queen Mary's Hospital and other hospitals like Avanti Bai and Dalkari Bai in Lucknow, which are government hospitals for obstetric care. And there, Pankha Gadgad chal raha hai, I was given a small table, and where I had to talk to those pregnant women, antenatal, who were mostly and still are mostly in the advanced stages of pregnancy, and just to pester them to give samples. I don't think hardly anybody was interested, neither doctors nor the patients, neither they understood, but just pestering helped me to get some samples. And I think we did take consent of these patients, but the point to tell is like the ethics of research was not that strong at that point of time. The students who will feel now were sometimes harassed by the rules and regulations of institutional ethics committee, they should really know the importance of ethics of research. And I'm very happy that now we are following all research protocols are being evaluated by the ethics committee. Our consents are and brochures are evaluated by institutional research committee. So this is a very important advancement there. So in 1989, finally in a year or two, I really could collect about 10,000 samples, and we had a data of RBC indices as a screening for beta thalassemia versus hemoglobin A2 estimation for the screening of efficacy of carrier detection for beta thalassemia. So it would happened, but it had nothing to really, it was like our department's effort, and it did not reach or may create any impact on the peripheral hospitals or doctors or lay persons there. And that is why when we in 2013, we thought of doing newborn screening program. And that time I was very skeptical about how if we can get particular samples from the patients, whether they will be cooperative and lot of things. So here, as I want to say, when we started our NBS program, we were very new to this type of screening program, and also very new to the outreach program. So both the aspects of this particular, our ambitious venture were very, very novel. And as we were establishing newborn screening program, we were trying to understand the system of NBS as well as running a logistics of an outreach program in the small hospital in various districts hospitals. So really, this is like it benefited both ways. We understood the experience of one gave the experience, learning of other, and the other way around. All of you may be aware of newborn screening program, but because this is a model to talk about outreach program, I would just briefly tell the history that in 1963, first prenatal newborn screening started, because doctors got to know, scientists got to know that though patients with phenylketonuria can be managed by phenylalanine-free diet, and their biochemically high levels of phenylalanine came down if the diet is restricted for phenylalanine. However, their intellectual disability did not disappear. And it became very obvious that if you want to prevent effects of phenylketonuria on brain leading to neurological abnormalities, one should start PKU, phenylalanine-free diet immediately after birth, before the symptoms appear. And hence the concept of newborn screening came. Then other disorders like congenital hypothyroidism or Biotinidase deficiencies, like where the early diagnosis before onset of symptoms would really change the course of the disease. Sickle cell disease and the cystic fibrosis, they may not have that miraculous outcome by newborn screening, but their outcome definitely changes. So many more disorders started getting into the list of newborn screening programs. And as you will see, most of the faculty in HGPGI would have got their screening done during newborn period if they were born in USA or UK. However, the tragedy is that now even we became grandmothers, still India does not have such government-supported newborn screening program. And newborn screening program, because we are treating before the symptoms appear. This is inconsistent with our ultimate goal in medicine, that prevention is better than cure. And hence, this newborn screening program is very essential and is present world over for so many years, more than 60 years now. Then what is different from a test? It is not a newborn screening test. Newborn screening test is done, but ultimately this has to be a part of a newborn screening program. Why I would tell, and as I said, the samples have to be collected from every hospital and should go to a central place or laboratory where the test will be done. So one may feel that there are many private pathology laboratories which are collecting samples from all over India, but let me tell you, this is entirely, the newborn screening program is entirely different than this type of private laboratories or collection center, because it not only involves getting the sample, but communicating to the result and then doing further testing and then follow up and then audit and lot of other things. So basically, it's a program and a system. The prototype, as I said, with what started from phenylketonuria, Other commonest disorder, especially very common for India, is congenital hypothyroidism. And the baby who is born is absolutely normal. And after 1 month of age also may look reasonably normal to a lay person. But when the symptoms become very, very obvious at 6 months of age, and then the diagnosis is written on the face, one can start treatment immediately. However, by that time, there is a significant brain damage and the child will be always mentally handicapped. Hence, it should be diagnosed during newborn screening, newborn period, and the treatment should be started within 10 to 15 days after birth. So this is a prototype and very success story and most important disease for including in newborn screening. As you say, see the slogan here, बेटी हो या बेटा अपना, स्वस्थ हो हर बच्चा, यह हम सबका सपना. In our newborn screening program, we have tried to associate it with the awareness about against female feticide. In India, still most of the people are really bothered if the child to be born or child born is a male or a boy or a girl. And hence we try to give the message that it's important that the whatever child is born is healthy, whether it's a baby girl or baby boy. And that is those are the messages we have printed on all our brochures and proformas. And the other disorder is Biotinidase deficiency. And the children, if untreated, develop alopecia, convulsions, status epilepticus, while the cost of treatment is only 10 rupees per day. And this can prevent mental retardation. As against this baby on this side, these are the two girls born to reasonably poor family, but because they were screened during newborn period from Barabanki, and the child, they got a medicine within time, and you can see they are absolutely normal with normal growth of hair and normal development, motor as well as cognitive function. I will briefly tell the story about the birth of that first elder girl because that reflects the main issues with the outreach program or a screening program like newborn screening program. As Dr. Vijayalakshmi said, that the child born externally looks normal. And then how do you tell the family that we are taking the sample because some of the children may have some disease, and if untreated, they may die or they may develop intellectual disability. So this is a really main problem. But many times nowadays we are telling that the child may have mental retardation, mandabuddhi ho sakta hai. Most of the parents agree to give samples, and sample is taken from heel prick by a small lancet, few drops of blood. So the sample was given, and as soon as we saw that the result and the child seems to have a profound Biotinidase deficiency, we called the patient. They picked up the phone. Now with mobile phone era, in fact, reaching the patient many times is reasonably easy. So the father said, yes, we'll come. Then after 3-4 days, he will said, we'll come. Then there were 2 home visits. And the sort of the parents, the dada, dadi and the grandparents said that child is all right and these people are sort of doctors are harassing you, don't go and everything. So finally, after almost 3 weeks or 4 weeks, when the child did not come, I did send Mr. Lal Prabodh for home visit, and we found that the child had convulsions, is admitted in other hospital in Lucknow, and where Mr. Lal Prabodh went, I talked to the Dr. Prajesh, who was very efficiently managing status epilepticus of the girl who you can see now smiling, and that neonate had status epilepticus, unconscious, and we did inform the treating pediatrician that she has Biotinidase deficiency, WhatsApp the report, and then we started, gave biotin, Lal Prabodh purchase, gave to the doctor, and then biotin was given through rice tube. And next evening, Mr. Lal Prabodh, who is not a doctor, but said, Madam, wo bachchi theek ho gayi hai. So the results are so dramatic. And now you can see, except some speech problems, I think she is absolutely normal. Her sister, younger one, she was diagnosed within 2 days, and then she was put on treatment, and she is absolutely normal. So this highlights the main problems in newborn screening. First important thing is it has to be done for everybody. And each case is equally important, because if you think that out of 1,000, one child is going to have the disorder, then which one that will be is a very, nobody can tell, and every case needs to be followed with that enthusiasm, and really we have to pursue for that particular case. So this I would not go into detail, but naturally when you choose disorders for a newborn screening, the easy treatment and really screening should be possible and outcome should be very good. And as I highlighted, this is a public health program, not only a collecting sample or test, and this involves complex system of testing, evaluation, follow-up, education, and so many people are involved. And every baby, practically every baby should be evaluated for or included in this newborn screening program. Many developing countries, or many of them, have started these programs for since 1990. And we naturally every country had different format, but basically you have to start it as a pilot program, which we did it in 2013. And these disorders become very important when the infant mortality falls less than 30. Then this contribution of genetic disorders become important. So in 2010 to 13, we had this newborn screening program, which was funded by DBT. It was in the research mode. We screened 3 disorders, and hospitals, 4-5 hospitals in Lucknow, Barabanki, Khairabad were included. We had got the samples because of the DBT funding. Then the most important, this pillar of newborn screening on this type of field work or outreach program are the field workers. So we trained the field workers with social MSW nursing staff as well as other BSc technicians, and taught them do's and not to do's, or all those things. And communication is very important. They should not feel threatened, and they should get adequate information. Very small things like we are giving such type of a bracelet of a paper, which can be strapped around the ankle or wrist of the child whose newborn screening is done. That धन्यवाद माँ, मेरी नवजात शिशु परीक्षण हो चुका है. So these are the small things which can help the family to accept it, and also it spreads message to other individuals in the society. This outreach program, as I said, it was going to different hospitals in and around Lucknow, and you can see the patients who are attending these hospitals. These are government hospitals in and around Lucknow, and most of the women and population of lower socioeconomic strata is attending these hospitals. And still you can say that we could collect samples from 73% of babies. And I would like to tell that the 25% babies which were missed were probably mostly because they got lost inside the hospital from this place to this place, and our field worker could not trace, or many of them sometimes are discharged early, but hardly any refusals from my parents. So this is the most important point I would highlight, that what we did screening program 30 years ago in 1989, we were very skeptical whether the parents would accept this or not. But now I think with vaccination drives, many other advertisements, and educated literacy, as I said, increased literacy is very important. And the small pamphlet which we gave to the mother or the relatives, most of them could read that pamphlet in Hindi, and probably that was the reason for acceptance of newborn screening. This feasibility we published in Indian Journal of Pediatrics, and the rough cost calculation based on study of about 13,000 babies. Cost of testing per baby becomes rupees 600 for 3 disorders. Cost per baby diagnosed is about 8 lakhs. Like if you test about 1,200, 1,300 babies, then you will identify one child with hypothyroidism. And if that hypothyroidism child properly treated leads and works for 40 years, after 20 years will generate about rupees 96 lakhs throughout the life. So this is something rough cost calculation to stress on the government that even this newborn screening is cost effective. Not only the parents are happy and their child with disability is prevented, but it is cost effective also. What I said that the parents and mothers could usually read and write, and this was the small pamphlet which we created in Hindi, which was part of it was also consent. And here also again, beti beti ho ya beta apna, swasth ho har bachcha yah hum sabka sapna. So such small pamphlet the parents could read and really give consent for that. Initially, we also validated this brochure by giving it to read and then asking these questions to the people fill a pro forma. And as you can see, in out of 64 individuals who were asked the questions based on the pro forma, all of them could really answer correctly, mostly. Do you think that it is justified that to test a baby by a pinprick, even if the baby is normal? If you are called for child treatment, again, will you come? Do you think every newborn baby should undergo these tests? So as you can say, most of the individuals or people, whatever their socioeconomic status may be, once they read the pro forma, they feel convinced about the utility of this particular test. And when we ask whether have you read information brochure related to newborn screening test, so out of 64 or 54 mothers said that they did read the pamphlet. So this indicates that such type of communication is very useful, and most of the time mother herself out of gave consent for giving sample. So otherwise inside the women's ward, usually the males are not allowed, and if the mother says she will have to ask her husband or father-in-law, then probably they cannot give consent. But this does not happen, and I think 2019 really is India and women are really liberated even from the lower socioeconomic strata, at least to that extent that they can take decisions for their children. So this type of experience helped in knowing us, learning about planning, policy development, and all that. So with this, our experience, we went to the government, and then this was the first slide, that if there is a will, there is a way. So we told that if you are interested, government is, policymakers are interested, then newborn screening can be done. That's what we have shown by this our experience. And then this newborn screening program and system based on the medical practitioners, government organizations, and our tertiary care hospital. So all these together, we can work together. And then National Health Mission of Uttar Pradesh, we presented our data and talked, we were able to convince them, and then they funded for us a newborn screening program. In 2015, we started. The first step, as I said, it was to create awareness amongst clinicians, doctors working in the various hospitals. Many of the doctors are pediatricians, MD pediatrics, and everybody has read this chapter of newborn screening. But still, because something which is not practiced, then one is really tend to forget the importance of that. So such type of meetings help to create awareness among doctors. For lay persons, I think we were really convinced that now if we go to the peripheral hospitals, we will be able to convince them. So this National Health Program, mission funded program was really a dream come true. And again, here also, we just tried to continue with our theme of against female feticide, girl or a boy, healthy baby is a joy. So these important issues of logistics, support of doctors, and awareness and acceptance by the population, we had really confidence now with our previous experience. And we named this newborn screening program as Sarvashish Navjat Shishu Parikshan Yojana. I think now newborn screening can be the first blessings to the newborn baby by the doctor as well as the grandparents. And we were decided these disorders. By that time, Indian Academy of Pediatrics also has suggested newborn screening guidelines and so on. They included about deafness also, which probably is a time that we should include it in our newborn screening program. whatever we had done, it got lot of exposure in the media also, and this really helped. And many times we were getting phone calls from the journalists about this particular newborn screening program. This newborn screening program now extended to one more district like Raebareli. So there were multiple hospitals in Lucknow, Barabanki and Raebareli. Again, training of more manpower, taking address. As I said, when this, after taking sample, this is the just first step, and you don't know which one of them will be screen positive, and we have to recall. So getting correct address, phone number, we learned that probably in addition to the patient's phone number, we can take phone number of Asha. Asha Bahu is the one government person in the village who is taking care of pregnant women in that village. So getting the phone number of Asha Bahu is very important. Good samples is very important. This can be easily taught, but still it can be challenging, because if the sample is poor, then the whole thing goes down the drain. Quality control at our lab level, that is something which we were very happy that we could pass these quality control programs. And the time frame which is expected, which we could really follow, so that by 10 days or so, we should 10 to 15 days, most of the patients with screen positive could be called for re-evaluation, get sample for venous sample for repeat testing, and so on. But this is a really difficult step, and Dr. Vijayalakshmi and her residents must be remembering how much you had to pester the field worker and then Lal Prabodh, and they have to call again and again and do some home visits and so on. So this continues to remain a challenge till we really have a village level health worker involved in our process, that we just call that health worker, and then probably that health worker can communicate to the patient family and so on. So this follow-up we thought can be helped by such type of website. And once we devise this website, which has also title Putra ho ya Putri, Swastha ho Shishu or Janmadatri. So really I was very happy, because action against female feticide is a very important point close to my heart. And though we are not doing anything great, but I think through this we could contribute to this particular cause. So this Sarvashish Navaja Shishu Parikshan Yojana website was useful in not only for giving information, but also it had patients can look into their phone and reach the website and track the results of their child. So it is something like whatever we track our courier, whatever our parcel we have posted, we track on the courier system. So that way we had made so that the parents can put the patient ID, get the report, and we had told. So I think it was really one important way to see that the reports are seen by the patient and they can come to us. Of course, still I don't think unless we call at hardly any patient with screen positive test might have come, but these are some things very easily doable ways where patient can look at the reports. These are finally about the results of more than 62,000 babies screened. Still 25% babies we missed, and you can see you can get some idea about the possibility idea about what is the prevalence of those, relative prevalence of those disorders. So these are crude estimates of population prevalence, but still important. This after this follow-up, audit, contacting screen positive, some screen negative. So long-term follow-up is very important to really justify that we have not really missed any babies. Our tests were true positive, and lot more things probably need to be done from our side also. We are trying to keep a follow-up of those babies diagnosed, like congenital hypothyroidism, many more babies. And during COVID time also, Mr. Lal Prabodh called many of these families and tried to get update from those parents whether the child is doing all right or not. This is very important. the Biotinidase deficiency, the daughters which I showed you they are like our adopted daughters, and we see that they get medicines whether the father can afford or not, and he also knows that if he keeps on pestering, we'll give him medicines, and he just makes it a point that he 3 mahine mein medicine khatam ho gaye. He is from a lower socioeconomic strata, and I understand even the small amount of money makes this thing. So Lal Prod and me, we take care that his medicine, the children, the daughters need medicine properly. And in between, after the father is also convinced, the Bua and some other people tried to stop the medicine. And in the lower picture, you can see the girl she became irritated, lost hair. That's what father told us. And then he was convinced that after starting medicine, she became all right. So I think treating such type of individuals long term is very, very difficult, but now they are convinced that the medicines are really doing good to the child, and if medicine is not given, it will be harmful. So many other disorders are there. G6PD deficiency, 1 in 300 or 1 in 400. And this is not a disease. So educating these mothers with G6PD deficiency, we have given them a list of drugs to be avoided in a laminated sheet. We called in between to them as a meeting, and then our residents tried to educate them regarding this. So it's a continued process and needs a lot of time from our side, which we are probably not properly giving. Dr. Bhatia wrote guidelines for congenital hypothyroidism newborn screening, and I think this is impacting the whole country as such. Our website also has some information about newborn screening, and those who are into childbearing age should really see these information. Screening for beta thalassemia, screening for newborn screening, and so on. There is a video of, which we made sort of a play, Dr. Vijayalakshmi, myself, and so on. So it was an interesting way to teach people about newborn screening. The video which is seen below with sunflower, it's a cartoon video to tell where there is an imaginary character like Bua, and she tries to educate the family with newborn screening should be done. So this Bua tells the younger people to go for newborn screening and so on. So a lot of different ways trying to educate people and create the importance about screening for newborn people. This is something very useful. So now after that, the third step is that DBT started a new program which is called Umid. These are unique methods of management and treatment of inherited disorders. And under that, we have given these two aspirational districts, which are little far away from Lucknow, and started during COVID time, and it has posed many more challenges to our previously learned this system of newborn screening. Here, the main problem is that as soon as the delivery happens, within 2 hours, the mothers run away. And we told that every mother now under Janani Swasthya Yojana gets some check of 2,000 rupees or something, but the mothers don't wait. The Asha Bahu collects the check after 3 days. Officially, they are discharged after 3 days. So a lot of things that really help, because of that, our coverage is not good. And now we have made another videos, which through YouTube, and many patients have these smartphones. So Lal Pramod and field workers share those videos. So rather than talking to each family every day the same thing, they can look at the video and listen. So it is easier than reading the pamphlet, and I think that will be very efficient. So we are trying to use that methodology to create awareness, and maybe Mr. Lal Prabodh will talk about it in bit. So lastly, we have achieved some basic format of newborn screening and outreach program for small villages. There is involvement of hospital doctors. When I went and had a meeting with their CMS and CMO, they were very cooperative, very excited. So there is awareness, support, but their still involvement is limited, partly because I think everyone is overworked and busy. Follow-up of screen positive cases continues to pose a challenge. in addition to newborn screening, we have also given objective of screening 5,000 women for beta thalassemia per year, antenatal women. But most of the women come for first antenatal visit somewhere in the late third trimester. So really screening for beta thalassemia at that gestation doesn't make any sense. So with this, our understanding of such type of system, how it works, now we aim at involvement of all hospital staff. They themselves can collect sample. It should become a part of a routine activity of maternal child health program. Early discharges, if they are there, then revisit after day 3 can be encouraged. I think if the pediatrician makes it a sort of compulsory thing, then probably they may come. Coverage of home deliveries can be done by teaching sampling to ASHA worker, linking each sample records to unique ID. National Health Mission gives a unique ID to the patient and mother. Also now Aadhaar card is also going to be linked. Gradually, if our all health records get connected to the Aadhaar card, I think we will have much better system of following these babies. And some softwares like automatic phone call for every 3 months, reminder phone calls every 6 month visit. So a lot of things have to be, we need to do and feel like doing, and we are planning. But as you know, again, it's really challenging. Time is also constrained, but I think we'll keep on doing and better system will come. So with this, I end my talk about this outreach program, our experience of outreach program, and Department of Biotechnology, NHM, everybody, PhD, PGI, and a lot of our staff in the peripheral hospitals. And most important pillars of this successful program are the field workers. Laboratory technicians and good quality laboratory work is important, but field workers who are in the hospitals and talking to the patients and getting samples, I think I really thank them from bottom of my heart, as well as I know that unless they are passionate about it, and I feel those who are MSW trained, they are really trained in the field work, and appointing such type of trained people really helps in the success of the program. So thank you very much.